Thanks very much. Okay. So thank you for bearing with me with those technical things. I'm delighted to welcome everybody this evening to the next part of our series of COVID health. This time what we're going to be concentrating on, very pleasingly in a way, is unlocking. So we looked at how everything was, how the medical profession were converting over to cope with the COVID patients. And now we are in a very good position, please God, that we're actually trying to unlock. We're unlocking all our the medical profession, the doctor's surgeries, and we're able much more so to go out into the open. And what we're going to be concentrating on this evening is how we can do so safely from the medical profession, particularly looking at going into the GP surgeries, going into hospitals, and the provisions that are being made. We're not looking at the government's guidelines of unlocking. I can give the government website, which is very helpful, and we've got the guidance there. We're going to be looking at really the view of our medics as to how to do so safely and feel confident doing so. And that's also what Emma's going to be looking at as well. So how we can feel assured about what we're doing when we go out. So the lineup this evening is we've got Stephen Mann, who's going to be looking at things from the hospital perspective. We've got Sarah Shelley from the GP and the local surgeries perspective. And then we have Emma, our psychologist, who's going to be looking at the psychology of unlocking. So, and the way we're going to do it is that each of our three speakers is going to speak for about 10-15 minutes. If you'd like to raise any questions, please do so in chat. There will be a few moments after they've finished giving their presentation for we can open it up, and if anybody wants to unmute themselves and ask direct questions, that will be fine, and we can do so after each one has spoken. But in the meantime, just post your questions in chat, and then either we can ask those as we go along, if they're clarification, or when they finish speaking. So I'd like to ask Stephen to begin, and then we look forward to hearing all of you. So thank you very much. Stephen, what I'm going to do is I'm going to pin you on video. Let's see, spotlight video, so that you have the floor, as it were. And I will mute everybody. And then if you unmute yourself.
Okay, good evening.
Yeah, you'll have to unmute yourself again now. That because I've muted everybody. Thank you. Lovely.
Okay, good evening, everybody. Well, welcome back to the COVID series. And thank you for inviting me back, Michelle, after the last one we did, which was in mid-April. The last time I spoke about COVID, you may recall, those of you that were here then, we were really riding on the peak of the wave at that time. It was mid-April, at the peak of the pandemic, when everyone was in the midst of lockdown. It was a terrifying experience. Nobody knew what was happening to friends and neighbours and the community at large. And somebody described somebody gave me feedback about the presentation that I did as if I'd just been on Milium in Gaza, the way I portrayed the activities going on in Barnet Hospital, where I work. We're out now in a different place, of course, and I'm just going to talk to you a little bit about, over the next 10-15 minutes, about where we're at in terms of provision of care within the hospital and how it has moved on over the last 2 or 3 months from where it was in April, and what the future is in terms of reconfiguring services. So, you know, obviously, just by way of introduction, you're all well aware, and I will stress that the impact of COVID on the health service and on doctors' lifestyle has been unparalleled. And the pressure of the workload generated by COVID, and the fact that the whole of the National Health Service in the UK and across the world has been diverted into COVID care, has meant that there was a huge suspension and reorganization of every other service. So in my specialty of gastroenterology, gastroenterology was pretty much put on hold from mid-March to June the 1st when we reopened the service. And what I'm describing in gastroenterology, which is my own specialty, is paralleled in other specialties across the board. During that time of that 3 months of COVID, we were doing emergency gastroenterology, but all the routine stuff got deferred and all the urgent stuff got deferred as well. And we were trying to accommodate it in parallel with running the COVID service. So from what you can hear from me at the moment is that all the elective and urgent services that we provide and the surgeons provide and other specialties provide were largely suspended because both staff and resources were redeployed really to protect patients from COVID. Now, as the COVID pandemic has come down to a sort of flat line, we've now gone from the sorts of hospital admissions that we had at the peak of about 70 cases per day coming through A&E at Barnet to a current number of about 4 or 5 suspected COVIDs per week. So let's say an average of 1 suspected COVID per day, and almost all of them are proven negative once they're swab tested. So we haven't actually had a new diagnosis admitted probably since mid-May, or about 4 to 6 weeks or something. Although there are many suspected cases, but they turn out to be negative. So in terms of gastroenterology, which is what I do, during the course of the pandemic, our day-to-day activity, which is a lot of which is to do with screening for cancer, whether it's bowel cancer or upper GI cancer, esophagus and stomach, that our activity fell to about 5% of its normal levels during the peak. So, that 5% was largely emergency work, and there are people who come through A&E needing emergency endoscopy, which we have continued to provide. But all the routine or urgent work that the GPs were referring to us were not really being addressed. And now, since June, there's been a whole reconfiguration of services, which I'm going to touch upon how we're doing it. So the objective of reconfiguring is how to adapt to the post-COVID world, trying to address and improving the patient outcomes and making sure that it's safe for patients to come back to the hospital and safe for staff who are providing the service. And given the fact that we have to be efficient with our use of resource and our use of staff, and we've all got sort of timetables and sort of, we're all on certain contracts, how we can deal with a huge backlog without having an impact on, work-life balance. So just give you a number, for example, currently in our world of endoscopy in Barnet and Chase Farm, we have a backlog of about 1,400 cases. Now that's a huge number. If you think that we normally do, let's say on average, we do about 10 cases per session and 2 sessions per day. So that's 20 per day times 5. So we normally do about 100, sometimes we do evening sessions. So that's between 100 and 150 cases per week. We've got 1,500 cases as a backlog on top of the daily referrals into the system. So trying to match the daily income, the daily influx of cases and dealing with 1,400 backlogs. So we've adapted, the hospital have reorganized itself into what's called COVID secure pathways, just like any other workplace or public sector environment or restaurant or shopping centre. So Barnet Hospital has got an A&E attached to it. So we've got patients coming in off the street who are potential COVID cases. They have very strict criteria and pathways to divide COVID clean and potential COVID patients. So it's divided physically and by staff and by excuse me, by perspex screens. So all the staff are regularly checked and we're screened, and all patients, as soon as they're admitted, they also get swab tested. Every patient now gets a swab test on admission. Whether you're having an investigation like a scan or whether you are being admitted to the ward, we have very clear COVID secure wards and potential COVID wards, which are physically separated by the ward geography and physically separated by staff geography. They're trying very hard to ensure that staff who are looking after non-COVID patients are not looking after COVID patients during the same working day. The other aspect is we have 2 hospital sites. So Barnet is a potential COVID site because of A&E. Chase Farm Hospital is a clean site. And that's where all the elective work takes place, whether it's elective surgery or the majority of the endoscopy. And there they have very strict criteria for every patient who comes into the hospital for their procedure. So for example, you could be coming in for a 5-minute gastroscopy with me. You need to get there, say half an hour before, and you recover for an hour or so after. So you could be in the hospital for two hours, 2.5 hours, but you need to have 7 days isolation prior to the procedure. And that's a big deal for patients to have to comply with 7 days of quarantine for a 5-minute endoscopy or a half-hour colonoscopy. Nevertheless, that's the only way that the hospital can ensure that the patients aren't going to potentially bring in COVID as part of the footfall of patients coming into the hospital. If you're having surgery and not a day case sedated endoscopy, so surgery with general anesthetic, I believe it's a 14-day isolation procedure because the risks there are higher. So up until now, of course, the public have been very carefully avoiding any necessary contacts with the NHS and the health service. During the peak of the pandemic, they were advised repeatedly on government briefings to stay home, protect the NHS and save lives. And that message is now no longer necessary because as a result of 3 months of deferral of everybody's routine workload, which includes our cancer screening, patients with those conditions have been put on the back burner now for 3 months, and they are presenting late. So you've probably read in the newspapers about cancers presenting late, plenty of conditions that people would have previously attended A&E for. They didn't want to trouble anybody, whether it was the GP or the A&E doctors, and they were terrified themselves of catching COVID by just walking into the hospital. So now what we're trying to address is bringing patients back to get those needs addressed, the non-COVID needs. So just to sort of impress upon people, I haven't seen a case of COVID since mid-May in the hospital. And I'm aware that patients with non-COVID conditions are presenting late, either through A&E with a late presentation, or because they've been waiting so long for their procedures or scans or whatever else it is that they're waiting for. So at the moment, what we now need to impress upon the public is that you can be assured that due to very strict COVID secure pathways and screening the population who come into the hospital, that's not going to compromise your safety and certainly won't put the NHS under any undue pressures that you were fearful of back in March, April, May. Other specialties like gastroenterology are also dealing with their services in very similar ways. We're looking at reconfiguring the way we do outpatients, for example. Traditionally, an outpatient department was heaving with multiple specialties all sitting in the waiting room, everybody waiting for an hour and a half for their appointment because we were often running late. And now, during the last 3 months, we haven't done any face-to-face consultations, hardly at all. We're doing a lot of telephone consultations. And I think that the future is really for the NHS to set us up with video consults. So we haven't got video consultations yet in our practice. We're doing a lot of telephone consultations. And quite frankly, it's quite backward because they haven't even given me a headset. I'm on the phone with one hand and I'm trying to type with another hand and look at the results and look at their endoscopy report with one hand while holding onto the phone. I haven't even got a loudspeaker on my phone. So that's how backward we are in the NHS. And I'm hoping, and everybody's hoping, that we can move forward with more advanced technology to provide a remote service so that you don't waste time looking for somewhere to park and giving up work and coming with somebody who's also given up work to come to a clinic. So that's the way the reconfiguring outpatients. I've mentioned A&E, which
Stephen, can I ask you a question that's come in?
Of course you can. Please, please.
Somebody's asking about how this works, the isolation, the 7-day or the 2-week isolation. Is it just on the trust that the patients are going to be compliant, or how does that work?
Okay, good question. I asked the same question too. Listen, in the UK, anybody who's going into quarantine that have come in from Italy is just based on trust as well. And the NHS and the private sectors, by the way, are all asking the same of the patients, and it's just based on trust. It's not being policed. So I had a private patient recently who was given the protocol, including 7 days isolation for his gastroscopy. And then he pitched up and he was very honest and said, no, I haven't been sticking to it. And they sent him home and he's had to be rescheduled. So yeah, the answer to that is it's just based on, you know, patient trust and honesty. I don't know if anybody else has got any more questions. It might be helpful to have some interaction. Gary Lau. So I've mentioned something about A&E. Michelle, are you looking at the chat, by the way? While I'm
Yes, I am. So hang on, there's one more question that just came in. Otherwise, I'd say if people want us to have a few minutes now, they can unmute themselves and ask live questions. Yeah, so Gary's asking whether the funding model for the NHS has changed, and so that the hospitals are being paid a flat rate, and so how does that impact on treatment?
Gary, I'm not sure where you're going with that question. I don't even know I know the answer to that. I'm a clinician on the shop floor, so I'm not seeing anything different in treatment.
Fine. Okay, so is there any live questions? Does anybody want to unmute themselves and ask Stephen any live questions about hospital, particularly Barnet, or how things are being dealt with generally in hospitals?
Yes. May I ask?
Okay, there is somebody. Let me have a look.
Hi, it's Laurent here. Hi, Stephen. Thank you. I would like to know, since the reopening of the pubs, did you see more, I mean, on the COVID side, did you see more cases or not?
Yeah, no, good question. In fact, Laurent, I was expecting to see a second wave already by now after the protest marches and the beaches in Bournemouth on the bank holidays. So the answer is no, we haven't. And I think largely, before I come to the pubs, the reason why we didn't see a peak, a second wave after the marches and the beaches was because that was all outdoors. And I think generally we consider outdoor. Hey?
It's the same as in the US. They didn't see any peak because of the protest because it was outdoors.
Correct. Now, the pubs have only just opened about a week or two ago, and we haven't seen any rises in cases. As I say to you, we're literally getting one potential COVID case coming through A&E per day, and they usually screen negative. So I'm not even sure we're admitting any new cases since mid-May.
Okay.
So,
okay.
Oh, that's very good to hear. Okay, one last question, and then we'll go on to Sarah, if that's okay. From Veronique, she's asking whether you think you'll return to face-to-face consultations at some point.
Well, personally, I would like to return to face-to-face consultation. I think you get more out of seeing a patient in front of you than speaking to them over the telephone. There's a lot of the nuance of the interaction that you miss on a telephone, you know, the sort of the non-verbal cues that you get from the patient. Doing a Zoom type of consultation works well, and we do that in private practice. We're set up for Zoom, and I'm happy with that. The only problem with it, of course, is you can't examine someone's abdomen or whatever it is you want to examine. So we are being asked at a consultant level to triage our patients based on the GP referral to whether we want to see them face-to-face or send them straight to a test like a scan or an endoscopy, or we can do a telephone consultation. It's actually quite difficult to do that because the information you get from a GP referral is often very tick box based, and many of our patients do go straight to test. We've been told that we're allowed to see them face-to-face once we've spoken to them over the telephone and we feel we need to examine them, but they still haven't got the wherewithal for us to do that. There's no clinic set up for me or a time in my schedule for me to actually do another clinic which is face-to-face for the odd case. So I think most of us are going to adapt to virtual. I think it's suboptimal, but it does save a lot of time and footfall in the hospital for the public.
Okay, thank you. And then last, and if you do this quite quickly so we can go on to Sarah, because I'm aware of the time, is Barnet Hospital typical of hospitals throughout London? That's from Zena. Thank you.
Yeah, I think it is. I mean, if you bear in mind that Barnet and Watford, I think, were the two busiest hospitals in London in terms of cases of COVID, and the fact that we've gone right down, I think that reflects London. I can't comment about the rest of the UK.
Fine. Thank you very, very much. Stephen, thank you. I'm going to ask Sarah now. There we go. Sarah, I'm going to mute everybody. So Sarah, you can unmute yourself again. You'll have to unmute yourself again, and over to you. Thank you.
Michelle, sorry, can I just ask you to let me share screen?
Sure. So I'm going to make you co-host.
Sorry, thank you.
No problem. There we go. Yeah, there we are. So you're co-host. You'd be able to share screen now.
Can you see that?
Yeah, we can see that.
Okay. So first of all, thank you to Michelle and to all the educational committee for doing this COVID series, and also for everything, for keeping us entertained, educated and connected during this really difficult time. It's been quite sensational what Nair have been doing. When Michelle asked me to do this talk, and I'm not used to a lot of public speaking, but I sort of bit her hand off because I was quite excited about it, because I think we think that we're getting the message across that surgeries are open and the NHS is open, but I'm hearing every day when I'm at work people saying, I didn't want to bother you, I've just been dealing with it at home, I thought you've got more important people to deal with. And that's quite worrying. So it's really nice to have the opportunity just to talk about that. So what I thought I would do is just sort of talk about some of the comments that people had, the thoughts that people seem to have, and some of the common myths about the NHS and GP surgeries. And please do feel free to ask any questions during it. So a lot of people say my GP surgery is closed. And if you turn up at your GP surgery, it does look like it's closed. The front door is closed. You can't just walk in like you used to do. And it feels very different. Certainly in our surgery, you have to speak through a buzzer to someone at reception, and it feels like we're trying to keep you out. But we've been open the whole time. In fact, during the peak of it, we were open bank holidays as well, and surgeries have been running the same hours as they have done. And just to know that even if the front door is closed, your GP practice is running as usual. There are contingency plans as well. So certainly some of the smaller surgeries who perhaps if the staff are sick and they have to close down, there will always be a contingency where local surgeries will take over care. So never feel that the GP is not available and open to you. But it feels different, and we have very different ways of working now. So this is not choices that were made by individual surgeries. This was guidance that came down from NHS England, that this is how we have to work now. It is changing, it is updating, and different practices may do things slightly differently, but essentially the idea is still the surgeries have to have the door closed. And we will be triaging, a bit like Stephen was saying before, we will be triaging everything before you can come into the surgery. Beforehand, so in the peak of it, we were really seeing very, very few cases. It was only if it was felt to be, it was actually quite a sort of grey area, because people we thought were emergencies and would likely need to be seen in hospital, we sent to hospital, because there was no point in exposing them to the GP surgery and then the hospital. But if we were worried about someone we didn't think we could manage it over the phone, then we would see, but it was very few cases. That is changing now, and we are doing a lot more. But you will access your GP surgery differently. So all practices now in Barnet have signed up to something called e-consult. So this means that any time, day or night, you can go onto your practice website and submit an email consultation, essentially. So you put in you'll be asked some questions about registration, date of birth, etc. And you put in what the problem is, and it will ask you, it's artificial intelligence, it will ask you some very specific questions about the problem. That is submitted to your surgery, picked up either the same day or first thing in the morning, and you will be contacted by your surgery. They say by the end of the next working day, but most surgeries are doing it much quicker than that. So that's, at 3 o'clock in the morning or 11 o'clock at night, if you've got a problem, you can do that. And that actually is working really well for a lot of things. telephone triage. So if you're not going to do it by email, you can book a telephone triage and a doctor will call you back on the same day. They will try and assess what's going on. They will ask you questions. We're a bit more technically advanced, I think it sounds like, than Stephen was saying in the hospitals. A lot of people have headsets. In fact, most people you talk to look like they're gamers now because they've got these very fancy headsets. But we're doing also a lot of video consultations. So that does give us an extra element of knowledge because we can pick up some of the non-verbal cues that Stephen was talking about. We're also doing, being quite imaginative. I've had husbands doing examination of neurological systems on their wives, or palpating their abdomen. You can get a feel. So we are getting quite a lot of information, but now also if we need to see people, we will bring you down. Okay, and I'll talk about what will happen when you come for a face-to-face appointment shortly. Throughout the pandemic, we have been doing baby immunisations, so trying to keep those up to date. We've been doing newborn baby checks, but they are being done differently than they would have been done before. But it's important those things have always been done and will carry on. But we are now starting to do screening again, and things like your cervical smear tests, some of the bowel screening, etc., which we haven't been doing. We're really keen to catch up on the backlog that Stephen was talking about before. So again, this is a lot what we're hearing. My GP is so busy, I shouldn't bother them. We need to protect the NHS, and that was the slogan, wasn't it, that we all heard time and again. The point of protecting the NHS was so that we could protect you, so that we could look after you. And now that the numbers are down and thankfully we don't have wards full of COVID patients, we want to see you. So don't worry that we're too busy and that someone else has a bigger problem than yours or someone else should get priority. Let us do the deciding. Okay, you phone us and tell us, or email us and tell us what the problem is, and let us be the ones to decide. If we don't think it's necessary to see you, if we can sort it out quickly, if we don't think it's appropriate, we'll tell you. But don't hold back from contacting us. Again, a little bit like Stephen was saying before, people worry it's not safe to come to the practice. A lot of our patients have been shielding for the last 3 months. They haven't left the house, and then suddenly they're being asked to come to the GP surgery, and that's quite a scary prospect. Our priority is to keep you safe and to keep our staff safe. As GPs, we are employers. We have a lot of people we need to look after as well, but safety is the priority. So we're only going to bring you down for a face-to-face appointment if we really need to. If we can deal with the problem over the phone, via a text message, via an email consultation, we will do that, or via video. If you need to go straight to hospital, we'll do that. But if we need to see you in the practice, we will make sure that is safe to do so. We'll check that you'll be asked questions about whether you or your family have got any symptoms suggested of COVID. We will be wearing PPE, and generally what we try and do is whereas before you would come in, we'd have a discussion about what the problem is, we'd be asking questions and then do an examination and then make a plan. The aim now is to keep the time you're in the practice to a minimum. So we will do the conversation on the phone or by video first, getting as much history as possible. We'll bring you in for the examination, and then generally we'll call you back again afterwards to make the plan so that you're in and out as quickly as possible, which again reduces your risk as well. So it does look very different when you go to a practice now. You'll need to wear a mask. The doctor or nurse who you see will be wearing PPE as well. You'll be asked to use hand sanitizer. You will have your temperature taken, usually with a sort of forehead gun, so we're not putting it in your ear, it's non-touch. The clinicians may look they will have a mask, apron, usually a visor or glasses and gloves as well. The surgery will look very different, so generally there's no waiting room. Again, like Stephen was saying, we don't want people sitting waiting for their appointment and mingling. So you'll usually be asked to wait outside until your time for appointment. and then you'll be taken straight to the examination room and then straight out again. And some practices, depending on their size, will have one-way system. So you come in one door, you have to go out another door. There may be zoning. Sorry, there may be zoning. You may not.
Okay, Sarah, I muted you. There was some there was some noise, so I muted, which includes you. So if you'd like to unmute yourself. That's lovely, thank you.
Okay, yeah, so there are screens up in front. I'll show you some photos in a minute of what my practice looks like at the moment, but there are screens up for the receptionist, and little things, like I say, you know, you won't, we ask you to come on time for the appointment because you won't be able to come in. You may not be able to use the toilet. So these are things you need to be aware of before you come. So this is what our surgery looks like now. So the waiting room, you can see at the moment just 3 chairs there. I mean, normally there's about 30 or 40 chairs and people, and it's often full. That was in the middle of the day. And as you can see, there's no one sitting there waiting. We have only certain rooms in the practice that are being used for examinations. So they have very little equipment in there, so they can be cleaned very easily between patients. We have a separate list so that patients, so the flow of patients through there is safe as well. There are signs everywhere, temporary exits, showing one-way systems, reminding you to keep a social distance. You can see the screens up there at reception, and there's again advice about how to put on and take off your mask as needed. We also have in primary care, in every borough has one, Barnet's hot hub, as we call it, or the acute assessment clinic, is in Edgware Walk-in Centre. So the walk-in centre, as you'll know, is not running at the moment. Only Finchley Walk-in Centre is running. And Edgware has been turned into a hot hub. So if practices have patients who they are worried have symptoms that could be coronavirus, either themselves or someone in their home, and they need to be seen, then they will be referred to the hot hub. And the whole point of that is that therefore we're keeping the GP surgeries as cold or clean sites, a bit like Stephen was saying Chase Farm is, where when patients with coronavirus symptoms are not seen there. And again, that's just to improve everyone's safety. And their staff are tested weekly for COVID. And obviously if anyone comes back positive, they're not allowed to work until that has, until they finish their quarantine. And that's being commissioned in by North Central London, who are now in charge of, is the 5 boroughs, Barnet, Enfield, Haringey, Camden and Islington are all working under the same umbrella organisation, and each borough has their own hot hub. I have to say I work there once a week. The first time I started working there, I was quite terrified. You know, people always say, oh, you're on the front line. GPs were not on the front line. Stephen and the hospital team were on the front line. And I was really nervous actually about going to the hot hub and what it would look like. But it's given me a huge amount of confidence in the system that we have somewhere like that. That's, again, even within the hot hub, we have hot and cold areas. Again, to keep patients as safe as they possibly can be. And it's been a really valuable clinic and really valuable thing for us to use. And that, even though we're not seeing the numbers now, that is going to remain being commissioned in case we get another wave. You know, we're planning for the worst while trying to open services up as well. But also so that, you know, again, Stephen mentioned suspected cases. Even if they don't test positive, we are seeing suspected cases. So we're being as careful as we possibly can, and we'll be seeing them in the hot hub still.
Sarah, sorry, yeah. Can I just ask some questions that have come in?
Sure.
Sort of relating to what you're talking about, the actual surgery. I mean, there are specific things like 3-month blood tests for diabetes. Are they being done? You know, how are you going to roll out the flu jabs? Is that, you know, for the autumn?
Yeah. So this is, I mean, these are questions, these things are changing all the time. And every week new services are opening. So up until, in fact, tomorrow, for example, Edgware wasn't doing blood tests, so you could get urgent blood tests done at Finchley Memorial and Royal Free. So some of the routine long-term condition screening wasn't being done. The Finchley Memorial blood tests are now back up to their pre-COVID capacity, and Edgware is opening from tomorrow. So yes, those things are now being able to be done. We've started over the past 3 or 4 weeks doing our long-term condition clinics in the practice. So we're not up to capacity yet, but those things are all opening up now, and it's a really important point and a really important question. Again, flu is the next big issue, actually, the flu jabs, and again, we're looking at in local areas. So some places are going to be using car parks, you know, having to try and get people in and out as quickly as possible. It's really, really important we get full coverage of flu vaccinations this year. So there's huge work going on into how we do that better. Again, using technology and to make things faster and quicker and safer. Different practices will be doing different things, and that is currently being looked at the moment.
Lovely. Can I just ask a couple of other things? House calls. Are you doing house calls at the moment for those who are shielding?
So the Hot Hub that I was talking about before are essentially being commissioned to do the home visits. So yes, we are doing home visits. Certainly individual practices have always and are continuing to do their some of the visits. So certainly end of life visits, palliative care, then that has always been done. Different practices are doing different things depending on their staff and how vulnerable they are as well, but there is capacity for whoever needs a home visit to get one.
Lovely, thank you. And I don't know if you can answer this, but Sally's asking, when PG COVID is over, can we see a return to surgeries as they were?
I think honestly, no. I think I don't think it's ever going to fully go back to how it was, and some of that is a good thing, and some of it's not. First of all, I think this is the new normal for a while. Unfortunately, I don't think any of us know exactly how long that's going to be for, but even with the low numbers, this is the new normal, and I think we do have to learn how to deal with that. I think for a large number of people, actually, the way of doing the e-consults or the telephone triage works absolutely brilliantly. You know, we've seen this across the country. Companies like Babylon, who have been doing this beforehand and getting huge numbers, particularly working age people, the sort of 20s, 30s, who don't want to take a day off to try and get an appointment to come down and sit in a waiting room for something that can be dealt with very easily over the phone. So I think there are some huge benefits, and hopefully those will stay. I think we all have some anxiety. I think we need to get the balance right. We need to get the balance right that if we do need to see people, that we can do that. And that's what we're trying to get at the moment. I do worry still that I think a lot of, certainly as a GP, a lot of our relationships, a lot of the therapy that we give is about the relationship and about the being in the same room as each other. And very often someone will come into us with one problem, and as they're 1 foot out the door will say, oh, and by the way, can I just mention? And actually that's really what their main concern was, but they were either not ready to say it, or they're too anxious about what the answer is going to be. And we all worry slightly that if everything's just done over the phone or an e-consult, that's lost. And certainly for our patients who are not technologically savvy, who don't have a smartphone and can't do a video consultation, then that has been a problem. But I think as long as we get the balance right and are aware of that and are flexible, then actually I think there's a lot of benefits. And I have to say, in our practice, we've been trying for the last 3 years to move to what we call a patient first model, where every patient is triaged by the doctor first so that they see the right person first time. Because actually within practices, different doctors have different skills. And if you've taken the day off work, or it's, you know, been difficult to get down to the surgery, and then you see someone say, well, actually, Dr. Shelley's better at the gynecology stuff, or Dr. So-and-so is better at the, you know, if you need an injection in your shoulder, that's very frustrating. It's a waste of an appointment. It's a waste of your time. And if we can get that right first time, that's good for everyone. So it is a balance, and we have to be flexible. And I mean, one of my next slides sort of says, bear with us. And I think
I think maybe we need to get to that. I just, before you go, because we'll move on to Emma. You've both said about come in. Have you got any special message about children?
So this is, if I can just do this slide, then I think that probably is the point. It's not, so children is really important. Again, unfortunately, we've seen too many cases of parents being terrified to take their children to A&E. If they're having an asthma attack and they're not getting it under control quickly. If they're having symptoms of sort of high fevers that aren't going away, bruising, we're seeing leukemias present late. We're seeing children in respiratory arrest because their asthma, the parents are trying to deal with their asthma at home because they're frightened. Please, please, please come in for those. Go to A&E. It is safe to do that. Come speak to the doctor if you're concerned. But all these things on this list are really important. So, you know, one of the things about COVID, what we do know is that the biggest factor for severity of illness is your underlying condition. So some of the things we can't change. We can't change our age. We can't change our sex or our gender or ethnicity. We can change if we're overweight. We can make sure our asthma, our blood pressure and our diabetes are as well controlled as possible. So getting those right by seeing the doctor when you need to is really important. Any symptoms that could be suggestive of early cancer, please speak to the GP about. If we catch things early, we can deal with them. If we're presenting late, then the chances of cure are much, much lower. And I would just, I am a Macmillan GP, and Macmillan have a great website with lots of resources, but particularly they have a page, signs and symptoms of cancer. So if you're not sure, look on there and speak to your GP. Children's health, we've talked about. Mental health, there's a lot, Emma will talk about that more, but there's the mental health.
Sarah, I'm sorry.
Okay. Domestic violence, please.
I can see.
This last one.
Yeah.
Domestic violence is in our community as well. Please ask for help. It's a really terrifying time for people who are suffering with that at the moment. So thank you.
Okay, well, as I talk to, leave that slide there until we have completely finished. We'll hand over to Emma. We can see all those particular conditions: children, mental health, domestic violence, COVID, looking after yourself, and long-term conditions, and also early cancer. So thank you very much for all those. I can see that there are a couple more questions. I think about children with temperature. Again, you've said, come in, you know, speak to the doctor. It's really, really important. I'm going to go over to Emma now. So thank you very, very much, Sarah. Now I've got to find Emma, don't I?
Hello everyone. Can you hear me? Can you hear me?
I can. So
lovely.
That's wonderful.
I'm just going to start. I've written a few things down. I'm aware of the time. We're a little pressed for time. So thank you to my husband for sharing his name today, because my audio was down. And two small disclaimers: that nothing I say is meant to contradict any of the medical advice that you're either given as individuals or today. And also nothing is meant to tell anybody what to do. So please try not to take this highlighted psychology aspect personally. It's just sort of general advice, not meant to tell you what to do and how to behave. So what I'm seeing in my work, and a good psychology point, is to be aware that people with a predisposition to anxiety and obsessive compulsive tendencies, and that includes even the thought version of obsessive compulsive tendencies without any obvious overt behaviors, are much more likely to be anxious and avoidant about venturing out. These people, you know, are much more likely to sort of even leave their house and follow the national guidelines, and will often perceive that there's a real danger to their life or that of their loved ones lurking around every corner. They're unlikely to socialize even within current guidelines, and they're likely to be heavily protecting themselves with almost PPE type of equipment, even in these outdoor spaces where, as the two doctors just highlighted, we're seeing that we are pretty safe. And we're also aware on the ground from Stephen's very happy account there of incidents of positive cases or lack of them, that we're probably less at this point of 1 in about 4,000 of even seeing someone in the distance who may have a COVID diagnosis. So incidents, thank God, even though we have to stay safe and follow guidelines, are, thank God, currently quite low. I've highlighted here a further point that people are very poor statisticians at the best of times, which is, of course, why many people gamble. They place bets against all odds of winning or even breaking even. And in fact, often, even those that don't suffer from technically gambling disorders spend in a year a huge amount of money on something they're highly unlikely to ever gain any profit from. Of course, when people are anxious, we become even worse at this. An example is I've, over my 30 years, seen a lot of people that have been in even very small road traffic accidents. It's a very big source of referral, particularly obviously from the insurance companies, because everybody has car insurance who has a car, almost. So when somebody has been in an accident, they, even if it's a very mild one, like a tiny hit from the rear, they often become very nervous to go back in the car, even though they've been happy, confident drivers for decades. They'll, of course, perceive and believe that they're highly likely to be in another accident. And this actually leads to a lot of avoidance behaviors where people even stop driving. So that's another example of people being a poor statistician. They're unable to weigh up the actual risk to them. We know also from those people, those of us, our friends and families who are scared of flying, that in people's minds, there's going to be a terrorist incident on that plane, and heaven forbid there's going to be a crash, even though, thank God, the statistics on flying are fantastic. And on the other hand, of course, we take risk-taking behaviors with apparently very little degree of anxiety at all. A favorite example of that, of mine, is actually drinking. People are quite happy to drink even quite large amounts of alcohol, but don't weigh up the risks either to their health or to the effect on the relationships with loved ones, on their chances of having an accident, and all the other detrimental effects that there are of drinking. They don't weigh that up very well when they make those decisions. Another example of how anxiety feeds into our, if you like, our perception of objectivity, if you want to call it that, is of course health anxieties. Which is a very big one. So people classically perceive even a very small rash as something quite sinister. And obviously medically it's important to get things checked out. But I think Sarah and others would agree that 5 times a day for the same rash may not be necessary. So it's that kind of balance again that she was talking about earlier. So just to highlight the point that people who are anxious are finding it very hard currently to venture out, and may be behaving much more like they're shielding in effect when they have no real underlying health conditions at all. I've then gone on to say a couple of points I personally have found interesting within the psychology of this time, and there are actually many interesting points that this has brought out. One is that, of course, the government guidelines and indeed our own need, particularly in the initial lockdown, to engage in avoidance behaviours is exactly that aspect that reinforces anxieties, reinforces OCDs in those that suffer, and indeed reinforces other tendencies towards mental health difficulties, including depression. So we know as psychologists, and we spend a lot of time trying to support people to reverse those behaviors. And of course, this is particularly now hard for those who have some of these difficulties, who may not have the support, may not have access so easily to a psychologist, who are actually just staying home far more than they need. And that's making their mental health worse. So I've said, obviously, this is particularly difficult. It's particularly detrimental also for the socially anxious, even though they may be delighted to be home and may actually be mega in their comfort zone, if you like. It's not good for them. They need to be pushing themselves outside of their comfort zones and sticking to government guidelines, not being 2 or 3 or 4 stages behind and behaving like somebody who's shielding when actually they shouldn't be. 2 other points I've been interested in, and I think if I'm interested in them, they're more likely to be interesting for you. One is the terminology and some of the necessary medical work that's been going on. So terminology of second waves and third waves and even lockdown, I have a bit of a problem with. They're all quite negative. They're all quite catastrophic. And obviously we need to be careful. But these sort of terminologies also reinforce anxiety in many. Anxious folk, or those with a propensity towards anxiety, hate uncertainty, hate the possibility of things being rolled out forever. And of course, all of these things are feeding into that negative psychology and making it harder for people. Others may be perceived perhaps unfairly as reckless. And obviously there are reckless folk, I'm not saying that there aren't, but one's idea about what is and isn't reasonable is also being changed in the current climes and the current fear levels for many. Stephen mentioned, and I was going to mention, the fact that it is fascinating to me that behaviourally all those folk who turned up on Bournemouth Beach or went to demonstrate, one, we don't seem to have seen spikes as a result. Because of that being outside. And also the beach gatherers, technically, behaviorally, from a psychology point of view, did actually nothing wrong. We were told to go out, we were told to get out and get fresh air and whatnot. The fact that they all turned up together is another matter of how that was policed, if you like. But behaviorally, they were actually doing the right thing. They were trying to get back to normal. So do try not to be too critical of others, too judgmental, because actually that's going to reinforce your own stance, and that may not always be helpful. So keep an open mind. Another point I wanted to raise in the few minutes we have left is really about how I've seen a lot of difficulties within families where a family member who's often particularly anxious, let me just get the right page there, may effectively be, in inverted commas, dictating to the other members of the family how to behave. Families can feel, I put it to folk, somewhat held to ransom by family members, where the anxious one is effectively dominating the roost. and becomes quite agitated, distressed, and even potentially aggressive in their wish to, in their mind, shield their loved ones from extreme danger in their mind. So I'm saying we don't want to contribute in that same debate about how any decision in life is a cost and benefit equation, isn't it? When we go on to medication, when we do any of the other things that we do, we weigh up the costs and benefits. So try to keep that balance in check. Try to look at the evidence for, the evidence against, and be aware that one of the big factors against is going to be negatively potentially contributing towards other members of the family's mental health by that control over what indeed they do, and potentially eroding the fabric of the positive relationships within our families. And I've said finally that surely is a very high cost to pay.
Okay, Emma, that's wonderful. Thank you very, very much. Thank you, all of you, Stephen, Sarah, Emma, you know, you're fantastic. Really try to give us every aspect of, sort of from the medical side, both physical and mental health, on how we can cope with, enjoy, and safely to lockdown. I realise that it's 8 o'clock and we really need to be wrapping up. But if I could give you 1 minute each, the second wave, somebody's just asked, how can we learn from what's happening in Israel at the moment? You know, this idea of a second wave. If you could just do 1 minute each on, and I'll start with Emma since you're there. What can we learn from Israel? How do we respond to a second wave?
It's more of a policy thing, I think, and I think I don't really have any psychology insights into that, to be honest. I think it's emerging on the ground. You know, try not to panic, try not to focus on the term second wave, because it's going to heighten your anxieties. And let's just see how that country deals with it, and perhaps we can learn positively from that.
Thank you, Emma. That's wonderful. Okay, so Sarah, shall we have you?
Yeah, I mean, I think the reality is that nobody really knows what's going to happen next. I think it's just, I'm sure a lot of you saw a message that went out last week about a small peak in the local area, and that the message that is just maintain social distancing, follow the rules. You know, NAIR is working really hard to follow the rules, and we just ask everyone the same: social distance when you can, make sure you wash your hands, be sensible, that's all we can do. And I think that's where they think it went wrong in Israel. They're very different from us. I don't think we can take it exactly the same, but if we can just follow the guidance and be sensible and make your risk assessment based on your family and your situation, then that's the best thing we can suggest at the moment.
Lovely, thank you. Thank you, very sensible, Sarah. Stephen, would you like to add anything to that? You need to unmute yourself.
I think Israel's second wave is actually a taller wave than their first wave, because they imposed such a stringent and early lockdown. So they had very few cases in their first wave, which was the opposite to us. I don't believe our second wave will hit the same level of intensity that we had in March, April, May. Secondly, if we were to get a second wave of any sort, clinically, we're much more better prepared. So at the beginning, we had no clue what PPE to wear, and the guidelines from public health were so fluid. We were getting messages on a sort of weekly basis about what to wear, what not to wear, when to wear what. So we weren't really very good at looking after ourselves or after the patients. And of course, we're seeing trials coming through with drugs that are available, which are helping the sickest patients. And, you know, I'm sure more drugs will come through over the next few months, and then over the next 12 months, potentially a vaccine. So I'm hopeful that the second wave will be better managed policy-wise, PPE-wise, and drug-wise, potentially.
Okay, fantastic. Thank you so much. It was fascinating, really interesting, and also I think you've made me and hopefully everybody else feel much more confident about using the medical practices that we have. And like Emma's saying, you know, being sensible about the guidelines as much as we can, not being over anxious where it's not necessary. I don't know if everybody wants to unmute themselves now, and we can just say thank you very much, or give a clap, or just thank you. So if everybody wants to unmute.
Thank you.
Thank you.
Thanks very much.
Thank you very much. Very interesting. And thanks, Michelle, for hosting.
Pleasure. Okay. Good night, everybody. Thank you.
Thank you very much.
Thank you very much.
No,
How do you get this daughter?
I see. You're right. Thank you very much.
Really cool.